This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined as always by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Orthopaedic Surgery, published in 2026, titled C2 Slope as an Independent Predictor of Cervical Lordosis Loss Following Laminoplasty. It comes out of the Spine Surgery Department at Peking University People's Hospital.
This is a topic that hits home for anyone who performs posterior cervical spine surgery. We know that laminoplasty is a mainstay for treating cervical spondylotic myelopathy, CSM, because it allows for decompression while theoretically preserving motion. However, the Achilles heel of the procedure remains the post-operative loss of cervical lordosis.
Exactly. When that lordosis is lost, leading to kyphosis or sagittal imbalance, patients don't just have radiographic changes. They experience exacerbated neck and shoulder pain, poorer neurological recovery, and a significant hit to their quality of life.
And that's the clinical dilemma. We need to identify who is at high risk before we take them to the OR. Traditionally, we've looked at the C2-7 Cobb angle or the T1 slope, but the authors of this paper argue those have limitations.
Right. They point out that the Cobb angle only reflects the cervical spine's intrinsic curvature. It doesn't account for head or thoracic posture. And while the T1 slope is useful, you usually have to look at the T1S minus CL mismatch to get a full picture of balance, which can be operationally complex to calculate in a busy clinic.
Which brings us to the star of this paper, the C2 slope, or C2S. Ilara, for our residents listening, how did the authors define and measure the C2S?
It's actually quite elegant in its simplicity. The C2 slope is defined as the angle between the C2 inferior end plate and the horizontal plane. Mathematically, it essentially approximates that T1S minus CL mismatch we just mentioned, so it acts as a single integrated indicator of the relationship between upper and lower cervical alignment.
It reflects the matching degree between cervical lordosis and thoracic inclination. If the C2S is elevated, it suggests that the current cervical lordosis is insufficient to match the thoracic inclination. These patients are often using excessive atlantoaxial hyperextension just to maintain a horizontal gaze.
That's a great way to visualize it. Now, looking at the study itself, this was a retrospective cohort of 179 patients who underwent standard open-door cervical laminoplasty between 2014 and 2020. They had a solid follow-up, at least 24 months.
And they split these patients into two groups based on how much lordosis they lost, right?
Yes. They defined lordosis deterioration as a loss of more than 5 degrees in the C2-7 Cobb angle at the final follow-up. Out of the 179 patients, 55 fell into that deterioration group. That's about 30